Yeah, so I'm Markita Suttle. I'm actually a pediatric intensivist at Nationwide Children's in Columbus. I am going to talk to you about a study that I did as part of the CAPCOR network, which is the Collaborative Pediatric Critical Care Research Network. It's the only NIH-funded PICU research network in the United States. And so we're going to talk about something that's a little bit different, kind of looking at therapeutic alliance between bereaved parents and intensive care doctors in the PICU. But thank you for having me today. It's an honor to be here. It's been awesome to hear all of the presentations today. And so hopefully this will provide you with a little bit of insight into things that we're working on. So just for some background, we know that parental grief after a child's death is intense and it's prolonged. There's been multiple studies that have shown that parents that lose children actually have much more intense grief than any other adult that experiences a loss. And we also know that parents whose children die in PICUs are at high risk for severe grief reactions and poor mental health outcomes. And so knowing these things, I've always kind of wondered, what do the PICU physicians or the intensive care doctors, do they play some kind of role, or can they possibly play some kind of role in minimizing these outcomes or improving these outcomes for our families? And so the idea of therapeutic alliance came to my mind. It is something that originated from the psychiatric literature describing the bond between a therapist and their patient, but it's been adapted for use in some clinical settings as well. And so therapeutic alliance is this multifaceted construct that reflects the quality of the relationship between a family and their physician. Ultimately, it's the bond that exists between a physician and a family. And it's been shown to have positive health outcomes for adults and children, specifically adults with diabetes, HIV, bulimia, and then children with cancer, obsessive compulsive disorder, as well as arthritis. So the aims of our study, or the aim of our study, was to determine the extent of therapeutic alliance that bereaved parents perceive to have occurred between themselves and their child's intensivist during their child's PICU stay. And we hypothesized that the extent of the therapeutic alliance reported by parents would be influenced by not only parent attributes, but child attributes and characteristics of the child's clinical course. So for the study design, it was a multi-center study. So it was conducted over the eight sites that are part of the CAPCOR network. And it was a survey of bereaved parents at 6 months after their child's death in a CAPCOR network PICU. And our participants were bereaved parents, either biological and or legal guardians, parents that were greater than or equal to 18 years of age, parents that spoke English or Spanish, and one or more parent of the deceased child within the same family were eligible to participate. So our methods, 6 months after the child's death in the PICU, the parents would receive a mailing, basically a big packet in the mail that included 2 survey booklets. So one for each parent, either mom or dad, mom and mom, dad and dad, whatever that the family situation was. And inside the survey booklet was several different measures that we wanted the parents to complete. The primary measure for our study was a measure called the Human Connection Scale, which is a 16-item measure of therapeutic alliance. It was originally designed for cancer patients and their interactions with oncologists, but we adapted the language slightly so that it could be used in the PICU for our parent subset. And this measure looks at therapeutic alliance across 5 domains, and those domains are physician understanding of the patient's concerns, mutual caring and respect between the 2 parties, the patient or the family understanding of information, the family trust in the physician, and then finally, overall collaboration between the 2 parties. And responses are recorded, it's Likert responses, with 1 meaning not at all to 4 a great deal. Other measures that were included in their survey booklets, one of which was the revised adult attachment scale. And so this is an 18-item measure that has 2 subscales. And so the point of this measure is really to calculate or to put a number to how adults behave in close relationship. It really asks the question, do these adults form secure attachments with other adults, secure or healthy attachments, or do they have an insecure attachment style? And those 2 subscales, or the insecure attachment styles that we're speaking of, are anxious and avoidant attachment styles. So are they anxious when they're in other relationships with adults? Do they avoid close relationships with adults? And you can imagine that if you are assessing in a study whether or not, you're trying to assess the bond between a parent and a doctor, whether or not that parent can actually form healthy relationships or form healthy attachments is important to the information that you are getting in your study. And then the parents also completed a socio-demographic questionnaire that asked them questions about their age, their race, their ethnicity, their educational level, marital status. Once the parents mailed back their surveys, we took that as kind of an implied consent that they were going to participate in the study. And after that time point, we would also do a chart review, and they got all of this explanation in their study form, but we would do a chart review to obtain child information. So we looked at the age, the race, the ethnicity, the diagnoses, so what was their cause of death, as well as their mode of death. So did they die by withdrawal of care, failed CPR, or brain death? Trajectory of death, so was this a sudden unexpected death? Was it death from a potentially curable disease? Was this death from a congenital anomaly? Or was it death from kind of a progressive deterioration with intermittent crisis? And then we also looked at elements of date, so PICU length of stay as well as hospital length of stay. So our statistical approach, we obtained performed descriptive statistics for all of our responders to get means and standard deviations. And then we also did mixed effects models to account for correlated data between parents of the same family. Candidate predictors for multivariable modeling were determined based upon our univariable analysis. So for any outcome variable that had a p-value of less than 0.2, those variables were considered candidate predictors for our multivariable model. And so for multivariable models, we did manual backward selection. We performed that on every single one of the multivariable mixed models until all candidate predictors had p-values less than 0.1. And then our statistical cutoff that we used was a p-value less than 0.05 for significance. So kind of the standard significance level. So kind of switching gears to our results and kind of looking at our population of parents and then also looking at information about our patients. We ended up with 235 parents of 158 deceased children. Of parents, 63% were female with an average age of around 38. 67% of parents were white and 15% were of Hispanic ethnicity. 90% of parents had at least a high school education and 75% were married. 92% of parents were the biological parents, and most parents had at least one other child other than the child that had passed away. Looking at our specific measures that we talked about, the human connection scale score. So our average score for our parent population was 51.4. I know that's just a number and doesn't make a ton of sense right now. And we called that moderately high. If you compare our human connection scale score, average score, to the other adult studies, there's about five, maybe even more studies at this point that have used the human connection scale. If you compare that to the other studies, it's not the highest score, but it's also not the lowest. Most of those studies had average scores in the low to mid 50s. In fact, the author, so Mack et al., who developed this measure, when they did their original study on adult oncology patients, their average human connection score was 54.6. So we didn't quite achieve that number, but we're within the ballpark. Looking at the revised adult attachment scale, so those numbers, the way they work, the higher the score, the more evidence of an insecure attachment. And so our scores for anxiety as well as avoidant attachments were 2.1 and 2.6. Again, comparing those numbers to other studies in the literature, specifically in pediatrics, some work that was done by this network on parents with complicated grief. They found an anxiety score of 2.4 and an avoidance score of 3.0. So again, not as high as that parent population, but still within the same ballpark. Looking at our children in the study, 55% of the children were male with a mean age of around 8. 31% died a sudden, unexpected death, and most died after limitation or withdrawal of life support. 25% of children died from cardiac causes and had an average ICU length of stay of 22.2 days and a hospital length of stay of 27.2 days. So kind of looking at our models, I didn't put all of our univariable analysis in here because it's just a lot of information. But I will tell you from our univariable analysis, there were only 4 variables that ended up being candidate predictors for multivariable modeling. And those were parent race, child trajectory of death, child mode of death, and hospital length of stay. And so when we put those 4 candidate predictors into our multivariable mixed models, we perform backward manual selection. Ultimately, the only variable that was found to be significant for our study was parent race. And we found that on average, Black families or Black parents had human connection scale scores that were 4.5 or 4.6 points lower when compared to white parents. So ultimately, that's telling us that parents and Black parents in our population are not forming as strong of alliances with their intensive care doctors compared to white parents. And if you kind of look at the average scores, you can see the average score for Black parents was 49 compared to 55 of our white parents. So that was obviously something that stood out to us. I was curious about that. There's a lot of literature that we'll kind of touch on in the psychosocial world over many, many, many years that speak to the Black community and the difference in terms of their interactions with the medical community. But for me, specifically for this study, I wanted to know if there were certain areas of therapeutic alliance that were discrepant between the two parents. And so I decided to look at the human connection scale by question, since it assesses therapeutic alliance over 5 different domains. I really kind of wanted to look at the average scores for each one of the questions to see, where were the differences the most. And so when you do that, when I pulled out, looked at all those 16 different questions, the 4 questions that popped up were these ones. So how much did you trust your child's doctor? That score was different for the 2 groups. How much did you feel like your child's doctor cared about your child? Asking, the parents about honest, do they feel like the doctors were honest with them? And then also, did you understand the doctor's explanations? So what I took away from this was, the biggest differences in terms of therapeutic alliance on this specific measure were with regards to trust and then communication between Black parents and intensivists compared to white parents and intensivists. And so for any of you that are kind of familiar with the history, or at least a little bit familiar with the history of the Black community with medicine in the United States, this isn't super surprising. I read a lot of the psychosocial literature looking at these kind of things in the United States, but there have been lots of kind of trust issues, communication issues between Black Americans and physicians and researchers for centuries in the US. So, Black Americans have endured slavery, medical and surgical experimentation. They have gone through segregation, all at the hands of white slave owners, white physicians and researchers. They've experienced the Jim Crow era. So all of these things have really created a very inconsistent relationship between Black people and doctors and researchers in the United States. And it's really created this very strained relationship with the medical field between the medical field and the Black community in the US, which I think is all over the news right now, considering the disparities that we've seen with COVID, and then also heading into the vaccination period of COVID and kind of educating the Black community and kind of convincing them to get vaccinated against this virus. So reviewing many, many of the psychosocial studies over the past 50 years, there have been consistent barriers that come up. So a lot of this research is consistent. Like there's themes that come up, and probably 3 of the biggest themes are in terms of like the reason behind this are medical mistrust, again, poor communication, and then also perceived discrimination or discrimination that occurs amongst the Black community. And so I think that aligns pretty well with what we found, trust issues and communication issues, but just kind of breaking that down a little bit more and skimming some of that literature. Looking at the medical mistrust, there have been multiple studies that I just put things that have been recent, kind of in the past 10 years here, multiple studies that have linked disparities in preventative healthcare for the Black community, treatment adherence, as well as patient satisfaction. It's led to those things because of this medical mistrust. Black parents specifically have reported decreased trust in the physicians that are caring for their children. But there is some data that shows trust in physicians improves when Black parents, when there's greater continuity of care. So when they can see the same doctor over and over and over, and when doctors use a partnership building communication style rather than a more authoritative or demonstrative communication style. Looking at poor communication, Black mothers have voiced a desire for personal connection with healthcare providers. They prefer providers who listen, who empathize, and who offer encouragement. a study that was done by one of my friends out of DC National, where it was not on bereaved parents, or it was basically looking at an entire PICU population of parents. They looked at their family conferences, and they found that when you are talking to these parents and using very patient-centered or empathetic language during these family conferences, regardless of the level of illness for the child or the acuity and whether the child lived or died, parental satisfaction rose. And I think this is an important study to point out, because close to 40% of the population here were Black parents. So I think that that's something that can be kind of extrapolated to this realm of poor communication. And then finally, discrimination as a source for why we may be seeing this divergence between these two different groups of parents. Black Americans have experienced discrimination when their symptoms or problems have been dismissed, when they feel disrespected, or when they feel like their perspectives are not acknowledged during clinical encounters. But discrimination can be minimized and therapeutic alliance strengthened when providers develop multicultural competence. So when they're educated about these type of things, when they're educated about how to interact with Black Americans or with Black parents or patients, when they express a belief in equality and empowerment, and when they demonstrate empathy, positive regard, and genuineness. Those are things that can help to decrease the perception of discrimination with Black Americans in medicine. So in conclusion, therapeutic alliance between bereaved parents and physicians is moderately high, at least for our population. However, it is lower with our Black parents when compared to white parents, which I am not altogether that surprised about. Future research should focus on identifying strategies to strengthen therapeutic alliance with Black parents, and should also examine the role of therapeutic alliance on bereaved parental health outcomes, since we know that those health outcomes can be quite poor for this population of parents. So that is all I have for today. If you guys have questions about that, I would be happy to answer any questions.
Thank you, Dr. Markita.
That's excellent study.
Thank you. And I kind of alluded to it. We actually are looking at how therapeutic impacts health outcomes and mental health outcomes for parents. So stay tuned. We are currently doing that analysis.